immunotherapy is becoming the fourth modality of cancer treatment, but as you can see, there is quite a number of reports from experimental studies showing that tumor growth and metastatic spread can be stimulated in experimental models. In clinics, probably the first evidence showing cancer-promoting effect, where the first evidence was obtained in trials, adjuvant trials with interferon gamma. In these trials, where the patients with melanoma, colorectal cancer, and small cell lung cancer were treated with adjuvant interferon gamma, survival of treated groups was shorter than non-treated patients. And probably one of the latest reports on possible powerful effect of immunotherapy in clinical situation is failure of some vaccine trials with melanoma patients. In some of these trials, shorter survival in treated patients were observed, and in another trials were stopped prematurely because cancer-promoting effect was becoming evident. And finally, I'd like to mention some results obtained by our group, in which we observed a decrease in survival in subgroups of advanced renal cell carcinoma and melanoma patients treated with interferon alpha. We were studying prognostic and predictive value of a panel of peripheral blood lymphocyte subsets using flow cytometry. Well, we studied a number of lymphocyte subsets, and among them we found one lymphocyte subset. It is CD lymphocytes having high expression of CD8 antigen and CD57 plus positive lymphocytes. I will not go into details, into immunological details, and I will talk about this lymphocyte subset. For sake of simplicity, I will call it this lymphocyte subset biomarker, a tentative biomarker. And what we see in this graph, well, these are advanced renal cell carcinoma patients. Blue bars represent non-treated patients, and red bars represent treated patients. So what we see, if this tentative biomarker level of this biomarker is above the threshold, we increase the median overall survival by treatment almost, actually more than 3 times. So the therapeutic effect is quite evident. However, if we treat patients with low levels of these lymphocytes, actually we decrease median overall survival. In non-treated patients, median overall survival is about 24 months, and in treated patients, only 14 months. The same lymphocyte subsets turned out to be important also in adjuvant treatment, in the survival of melanoma patients treated with adjuvant interferon alpha. These are stage 3 melanoma patients. These are patients in whom metastases in regional lymph nodes can be removed, and then they were administered interferon alpha. As we see, Kaplan-Meier survival curves are they quite differ depending on the level of the CD8, CD57 plus lymphocytes. Of course, we were not able to have a group of untreated patients, but it's well known that non-treated stage 3 melanoma patients without treatment survive. 50% of these patients survive 5 years. So the curve of untreated patients must have been somewhere between. So again, these results suggest that in a subgroup of melanoma patients, adjuvant interferon alpha has probably cancer-promoting effect, detrimental effect, while in another subgroup of patients, probably we increase the survival. So, in conclusion, I think that the evidence we have reviewed tells that the cancer-promoting effect by current cancer treatment modalities cannot be excluded. In many cases, it is difficult to prove this effect because, as we all know, in current cancer clinical trials, usually a group of untreated patients or placebo group is not acceptable. So, without untreated patients, well, it is difficult to prove the cancer-promoting effect, but so it remain obscure. Further, I would like to think that large clinical trials perhaps are not justified because the more patients we include in the trial, the more patients risk to be cancer-promoting effect. And the most important point is that the possibility of a cancer-promoting effect is an urgent stimulus to introduce and to use the predictive biomarkers, because ignoring these predictive biomarkers, we cannot be compatible with the ethical principle, first do no harm. I'd like to thank my Dutch colleagues who were helping me with the study, to work together. And finally, I would like to finish my talk with a brighter view, which probably predictive, preventive, and personalized medicine will bring to us. Thank you very much.